Hello and welcome to our online information session. My name is Colleen Tewksbury. I am the Bariatric Program Manager and a Senior Research Investigator for Penn Medicine with the Penn Metabolic and Bariatric Surgery team. Now, the whole point of this video and this session is not for you to memorize everything that I'm about to go over. The purpose of this video is to give you an idea of what you could expect if you were to choose bariatric surgery as your treatment option, and also what you could expect from us if you were to come to Penn Medicine for treatment. So, with that being said, let's get started.
Here's a list of everything we will be reviewing today to give you some expectations as to all the different points we'll be going over. We are one of the longest standing practices in the area with more than 20 years of experience, and we perform approximately 850 surgeries every year. Now, that is something that we tell you not as a point of, woohoo, look at us. It's actually really important from a safety perspective. Studies have shown the more cases or the more surgeries a single center performs, the lower the rates of complications. And that makes sense. If you're going to a center where this is what they do, day in and day out, you would expect there to be lower rates of complications. And we're no different. As a part of that, we have won multiple awards and certifications, and also we maintain multiple accreditations. But that mainly is because of our subspecialized staff. We have phenomenal clinicians on our team, all of whom have had additional training specifically in bariatric surgery. So our surgeons are all fellows of the American Society for Metabolic and Bariatric Surgery. We have certified bariatric nurses. Our dietitians have advanced training in weight management, some of whom are certified specialists in obesity and weight management as well. And even our psychologists and our anesthesiologists are subspecialized in bariatric surgery. So because we are a subspecialty center and we are also an academic medical institution, you have access to the latest treatment options. That includes an enhanced recovery protocol that we currently have to get people healed faster and up and back to life quicker, reducing opioid use, and an app that we've developed, along with robotic assisted surgery being standard within our practices.
Here we have listed out our practicing surgeons. We have in total 7 surgeons who are operating at the 3 downtown hospital locations. Each of their profiles you can find at pennmedicine.org/bariatrics to be able to look through what their background is, their training, what academic appointments they have, even patient ratings are all up on our website for you to do some research and figure out which provider would be the best for you. Before we get into the weeds about obesity treatment, it's important that we're all on the same page when we're talking about what is obesity. So obesity is diagnosed using BMI, or body mass index. So that is just a weight to height ratio, kilograms per meter squared. Now it is a technically crude measure. It's only height and weight that we're looking at here, but it's a really strong predictor of long-term outcomes, namely one being death. So this graph here is showing the risk of death based off of body mass index. So on the y-axis here, we have risk, relative risk of mortality or death, and on the x-axis, we have body mass index or BMI going across. And what studies have shown is that the higher somebody's body mass index, the higher their risk of death. This is similar to other chronic diseases. So let me give you an example. Think about hypertension. How we diagnose someone as having hypertension is that they have a higher blood pressure. The higher someone's blood pressure, the higher the risk of death. That's how we come up with those categories of pre-hypertensive or hypertensive and having a diagnosis of hypertension. And the ultimate treatment for it is to bring down blood pressure to bring down risk. Obesity is no different. It's a chronic disease. The goal of the treatment of obesity is to try to bring down body mass index to reduce the risk of mortality, reduce the risk of death. So when we're talking about obesity, there are lots of other benefits of seeking treatment, right? There are other things that obesity can impact. But when you're talking to any of our clinicians, the foundation of this is that one of the primary treatment goals is to try and reduce that body mass index to reduce the overall risk of death. And that's really what we're talking about when we're talking about clinical treatment. Of course, again, there are other benefits of treating obesity, but this is really the primary foundation of what we're talking about.
So this diagram is showing that head to toe, just about every organ system is negatively affected by carrying excess weight. And many of these we hear about, of diabetes, sleep apnea, high blood pressure. Others we don't hear as often, like cancer risk. So we oftentimes talk about different risk factors for developing cancer. The top one is smoking, but the second strongest risk factor for someone developing cancer in their lifetime is actually their weight status, if someone has a diagnosis of obesity. So again, there are lots of other parts of the body that obesity impacts outside of just carrying excess weight. The purpose of this diagram is not for you to try to read it. It is meant to be visually overwhelming. This is the obesity system influence diagram. It is a visual representation of what affects weight. So we have in the center energy balance, basically calories in, calories out. Now, as a dietitian, I will oftentimes hear it's all about what food you're eating, right? This section here in the purple is what food you're eating. It is just this section here. What is in the food that you're eating and your access to food is over here off to the left in food production. Then we have your individual physical activity and activity environment. Up in the left-hand corner, we have social psychology, so that includes things like peer pressure or weight bias. Then we have individual psychology, so that includes things like self-esteem or internalized weight bias. We have overall physiology, and we'll talk a little bit about gut hormones today and how they're affected by surgery. But our makeup from a physiological standpoint really isn't built for us to be able to lose weight easily. Fighting Mother Nature is hard. Weight loss is very difficult to do because our physiology is built to prevent it. And then we have individual physiology, so someone's genetic makeup. We know that genetics account for about 30 to 70% of someone's weight status, specifically mother's weight status. That's actually the strongest predictor of what a child's weight status will be when they're an adult. It is not determinative. So again, it's about 30 to 70% depending on the study that you're looking at, but genes are not the end-all be-all. So keeping that in mind, it's one of the strongest factors in developing your weight status and gaining weight, but it's not determinative. So this shows how intricate and complex all of these lines connecting food intake to physical activity and your individual psychology with your genes. It's all very interwoven. It is not as simple as just eating too much and not moving enough. And we know that clinically. This is a map to help visualize that it's very complex how someone gains weight. But that also means that the treatment intervention should be just as comprehensive and making sure that you are trying to hit as many of the points on here as possible.
How do we treat obesity? This is a table that summarizes what current options we have for treatment. Each column represents a body mass index category, and each of the rows is a bucket that we have to pull from for different treatment options. So the first treatment option that we have is diet, exercise, and behavior therapy. There are all different types of approaches to this. The gold standard for weight management is what we call intensive behavioral therapy. And this typically ends up being 14 visits with a registered dietitian or trained behavior modification clinician for over a 6-month period. Now, there are all different types of interventions for diet, exercise, and behavior therapy, but for the high-level ones, we typically end up seeing about a 5 to 7% total body weight loss on average. There are some outliers to that, but that is typically what we would expect. That is the first line of treatment, diet, exercise, and behavior therapy, starting with a BMI of 25 or higher. Now, once someone gets to a BMI of 27 or above with a weight-related condition, or 30 or higher with or without a weight-related condition, 5 to 7% total body weight loss is typically not enough weight loss to bring down their body mass index enough to really reduce risk. So that's when we start talking about adding on weight loss medications or anti-obesity medications. There are 6 FDA-approved ones available on the market currently, and there are different options of combining them with diet, exercise, and behavior therapy treatments. Now, when adding in medications, we typically expect someone to lose about 7 to 10% of their total body weight loss. Again, there's some variation within this depending on the medication and the treatment approach, but this is on average what we would expect. If someone has a body mass index of 35 or higher with a weight-related condition, or just a body mass index of 40 or higher, 10% total body weight loss is typically not enough to bring down their body mass index far enough to lower risk enough. So that is when we start talking about surgery. Surgery typically provides 20 to 35% total body weight loss, depending on the surgery and the individual, but that is the general overarching range. Now, as a dietitian, we hear this often, right? Diet, exercise, and behavior therapy. You can do it almost as if sheer willpower will help someone lose weight. Unfortunately, studies have shown that that's just not the case. We know clinically that that's not what that treatment option provides. We would not expect very large weight losses from diet, exercise, and behavior therapy alone. And that's really the purpose of adding on the anti-obesity medications and also surgery. There was one study out of the UK a few years ago that actually estimated the odds of someone with a body mass index of 35 or higher reaching a body mass index of 25 or below through diet, exercise, and behavior therapy could be as little as 1 in 1,300. So the idea that it is something that is an effective treatment option, it is, but only to a certain point. For someone who has a significant amount of weight to lose, that is when we typically talk about these more rigorous and robust treatment options.
Let's talk about how the process works. Overall, it is a marathon. It is not a sprint. The first step in the process you are completing right now. It is attending an information session. The second step is to complete a first visit.
We are currently conducting just about all visits via telemedicine. And the specifics of utilizing telemedicine, if that were the mode of visit, would be sent to you prior to your first visit with us. At that first visit, you would meet with one of our team's nurse practitioners. They would review your entire medical and surgical history. They'd also do a physical exam if you were in office. They then would review all of the testing that would be needed prior to surgery. Some of this is required by insurance. Some of this is required by the program from a safety standpoint. Your nurse practitioner would review each of these tests and also the rationale for undergoing these tests at this visit.
At that first visit, you would also meet with one of our dietitians. They would learn everything about you from a nutrition standpoint. They would then also review the medical weight management process and what you can expect for your specific insurance plan. They'll also talk to you about support group and we are working currently to provide some technologically savvy ways of supporting you from home. So they'll review any upcoming events during that visit. They'll also review the $275 psychological consultation fee and whether or not you would be responsible for that based on your insurance. That fee is typically not due until at least 2 to 4 months into the process, so you would have plenty of time if you were responsible for that. However, the dietitian would review it with you at that first visit. They would also talk to you about the nutrition fee. The nutrition fee is $200. It's due 2 weeks prior to your surgery. And at that first visit, the dietitian again would let you know whether or not you would be responsible for that based on your insurance. That fee covers you to see a dietitian every single one of your visits. We do not bill for you to see a dietitian with our visits at this current time. So this fee covers you to be able to meet with them at each and every visit throughout the process. We do not limit your interactions with the dietitian. They'll also review with you if there's any concerns about possible weight restrictions on certain equipment for coming in person. You would then meet with the surgeon as well, talk about your surgical options, and review any of the specific risks for yourself associated with the surgery. If you are in person and you are both in agreement on which surgery you would like to pursue, you may also sign consents at that first visit. The last step of the initial process is to then schedule all of your testing and your medical weight management visits. That may be during your visit or immediately following with a phone call from one of our surgical coordinators or surgical schedulers. And we will also provide you with our direct contact information as well. The next step in the process is the assessment and medical weight management process. This includes completing all the tests that the nurse practitioner reviewed at that first visit, starting to complete medical weight management, and then the final steps for 2 weeks prior to surgery. Medical weight management is an insurance mandated time period for anywhere from 2 to 6 months prior to surgery. These involve monthly visits with a nurse practitioner and a dietitian. It is your time to practice any of the changes that come with surgery. It's also your time to attend support group and complete any of the testing that we ordered at that first visit. Now, it's important to keep in mind that just because someone meets the minimum amount of time that their insurance requires, if it's not safe to proceed with surgery, we will not proceed with surgery. Now, what do I mean by that? I will give you a specific example. So, let's say someone gets their blood work done at the end of medical weight management after 3 months of visits, and their insurance requires 3 months. And their blood work came back that their hemoglobin A1C was 12. Now, for anyone who is familiar with hemoglobin A1C, that is an average measure of your blood sugar over the last 3 months. And 12 is about double what we would expect it to be. Having high blood sugar and very high blood sugars going into surgery is very risky. If anyone has ever heard of non-healing diabetic wounds, the same goes for surgery. If someone has a hemoglobin A1C that high and undergoes a surgery, the likelihood they're going to have issues with healing afterwards is pretty high. So that is risky. Instead, what we will do is set you up with an endocrinologist if you don't already have one, and help you get that number down to bring down the risk of any complications with the operation. So then we would proceed with surgery. So again, just because someone meets the minimum requirements of their insurance, if it is not safe to proceed with surgery yet, we will not proceed. That doesn't happen often. We will work with you, and we are very transparent throughout the process, but we do want you to keep that in mind with going through the process. Now, because of that, we do not schedule surgery until you've completed medical weight management. We are transparent throughout the whole process and talk to you with every step about what you're looking at for different scheduling items and keeping you moving through, but keeping that in mind that we do not talk about a surgery date until you've completed the medical weight management process.
During medical weight management period, your nurse practitioner and potentially your surgeon will discuss with you some of the recommendations around substance use. Here's a table summarizing some of the recommendations for the most common substances we discuss with patients. If any of these pertain specifically to you, we would discuss with you on a one-to-one basis. The nurse practitioners would also discuss throughout medical weight management to any women of childbearing age the risks of becoming pregnant while having obesity, and connect individuals with any specific clinicians that they may need to see and any additional services that they may need both before surgery and after surgery to help actively prevent becoming pregnant and reduce risk overall.
The last steps before surgery include what we call a history and physical. It is where we do a one last review of your medical and surgical history and a physical exam. We also have you complete pre-admission testing. That currently also includes testing for the novel coronavirus within a specific time period prior to surgery. We then also have everyone attend our nutrition and nursing class, which we are also providing as a telemedicine appointment. This is required for all patients to attend, and we review the nutrition recommendations one final time prior to surgery, and we also go over what you can expect one last time for while you are in the hospital. This is the time point that $200 nutrition fee is due if you are responsible for that fee based on your insurance. The next step in the process is surgery itself. Most individuals can expect anywhere from 1 to 3 overnights in the hospital, and your surgeon would review with you individually what you can expect for your length of stay for the operation you are choosing. The first operation we'll review is a Roux gastric bypass, which you'll sometimes hear referred to as a gastric bypass or just a bypass. Now, this surgery is where your surgeon creates a small egg size, and we mean egg size pouch, at the top of your stomach. They disconnect the intestines about a third of the way down and connect them to the pouch and also further down the intestines. So instead of food going down your throat, down your esophagus, and into your stomach, then into your intestines, it now goes into that little pouch at the top of your stomach and into what we call a Roux limb, down that Roux limb, and digestion begins at what we call the Y junction, where it meets back up at that other point of the intestines. For most foods begin to get digested there. Now, no food touches the stomach or that first third part of the intestines. So that is why we call it a bypass. It's bypassing that part of your stomach and your intestines. This is restrictive. Most people can only eat maybe 1 to 2 ounces in the beginning. They also typically malabsorb or don't absorb about 10% of what they eat, which can also lead to what we call dumping syndrome with high sugar foods and drinks. This is where somebody has this shaking, sweating, heart racing effect. Studies have shown that most patients who have a gastric bypass experience this, but up to about 1 out of every 5 patients say that they don't experience dumping syndrome if they eat sugar. So this is a potentially beneficial aspect of surgery for many people, that they view if they eat something high in sugar, they may feel sick afterwards, but it's not a guarantee. Many people don't end up feeling sick, so it's something to keep in mind. But that could be a potential deterrent for many people that they find helpful. Now, with gastric bypass, we do see changes in hunger and satiety hormones. So what that means, there's this hormone in your stomach that's produced by your stomach called ghrelin. It gives you that burning hunger, grumbling sensation. Immediately after surgery, we see with most individuals how much ghrelin your stomach makes drops. people typically do not feel hungry after surgery. Eventually, that ghrelin comes back slowly, but typically not to the level that it was prior to surgery. So for most individuals, they don't feel the same level of hunger that they did beforehand, which can be helpful. Now, on the flip side, we also see a decrease in satiety reaction though. So not only are people not feeling extremely hungry, we typically don't see that they feel extremely satisfied either from a hormonal standpoint. This tends to re-regulate over time, but we don't typically expect for individuals to reach that extreme levels of either hunger or satiety again after surgery. So both pros and cons that come with that, but something to consider when making your decision. The second surgery we will review is a vertical sleeve gastrectomy, oftentimes just called a sleeve. So what this surgery is, your surgeon would remove about 7/8 of your stomach. It is relatively simple. You would be left with a small sleeve of a stomach, almost like a banana. Most individuals can eat about 2 to 3 ounces of volume in the beginning, but there's limited malabsorption. There's no bypassing here. So typically, some individuals may experience some reactions to high sugar foods, but it's not what we would consider to be dumping syndrome. With this operation, though, we do also still see the changes in hunger and satiety hormones for most patients, that most individuals report not feeling as hungry. They don't have as much ghrelin after surgery, which can be very helpful when trying to lose weight. Laparoscopic surgery is the main approach that is used for bariatric surgery. What does that mean? So laparoscopic surgery is where your surgeon creates only 5 to 6 small incisions to perform your operation. 2 of those incisions are typically used to actually perform the operation. 2 are used to use tools to hold things in place while performing the operation. And then 1 is for the camera so that your physician can see inside of your stomach, inside of your abdomen. Sometimes individuals need a 6th or a 7th incision, depending on how difficult it is for your surgeon to access everything they need to access. Your surgeon would review what their plan is with you individually. Now, what are the benefits of laparoscopic surgery? Laparoscopic surgery typically reduces the risk of bleeding, reduces the risk of severe scarring. It lowers the length of time expected for recovery. It is typically associated with lower risks of blood clots, lower risks of infection. So overall, all positive things. The next step in the process is healing and immediate follow-up. So we recommend that individuals follow up with us within 2 weeks of surgery and again at 6 weeks. What are we worried about for those first few weeks out from surgery? So this is an analysis of surgeries out of what's called the MBS-AQIP database. We are looking at over 450,000 surgeries of gastric bypasses and sleeve gastrectomies from 2015 to 2017. And what are the rates of complications? So within that time period, 4% of individuals had to be readmitted to the hospital within the first 30 days. The most common reason was nausea, vomiting, fluid, and electrolyte depletion. 1.3% of individuals needed to have a reoperation within 30 days of surgery, most commonly for bleeding, a leak, or intestinal obstruction, something getting stuck in the intestines. 1.4% of individuals needed an intervention, most commonly getting IV fluids for nausea, vomiting, fluid, and electrolyte depletion. 0.08% of individuals experienced a life-threatening complication, and 0.09% experienced mortality. Now, for both of these, we actually have pretty strong predictions or factors that would increase someone's risk for experiencing a life-threatening complication. and potentially mortality. So when you sit down to consent to the procedure with your surgeon, they would review with you specifically if they had any concerns for any of your conditions that may put you at higher risk. But overall, these are comparatively very low complication rates compared to other gastrointestinal surgeries.
For each of the potential complications that could occur with surgery, we do have multiple risk reduction strategies in place. Some of them are listed here in this table. As you go through the process, we will review them with you and make sure that you're aware of some of the things that we do ask that patients participate in and some of our recommendations around medication use and operation room practices. We do utilize these practices primarily to reduce risk of potential complications.
The diet after surgery is progressive. You start off on all liquids and slowly work your way up into solid food over about 2 months. We do recommend that individuals keep track throughout that time period, and it is extremely challenging to, if not physically impossible, to consume enough food in the beginning to get in enough vitamins and minerals. So supplementation of vitamins and minerals and protein in the beginning are key. You will meet with a dietitian at every one of your visits to work through this and to be prepared and to navigate this well. But it is important to keep in mind that how someone is eating at 6 months out from surgery has been shown to be predictive of what their weight looks like 10 years out from surgery. So the nutrition component is an extremely important part of this process, and all the more important to work with the dietitian throughout this process. The last part of the bariatric surgery process is lifelong follow-up. We recommend that individuals follow up at 3 months, 6 months, 12 months, 18 months, and then once a year at minimum from there on out after surgery.
Long-term after surgery, there is the possibility of some late occurring complications. We do additionally have different risk reduction strategies for these complications as well. Some of them are listed out here in this table. We would address these with you and screen for some of these and help you prevent or reduce the risk of developing some of these complications at your long-term follow-up appointments.
There are lots of benefits to exercise. Weight loss is typically not one of them. The purpose of exercise during weight loss is typically to help reduce the risk of developing osteoporosis or breaking down bone. It's also there to help you lose more fat tissue than muscle tissue. We want to make sure that you are trying to hold on to as much muscle as you can as you are losing weight. It is also one of the strongest predictors of someone keeping off their weight loss long term. If someone is not exercising while losing weight and while maintaining their weight loss, studies have suggested that less than 1% of those individuals will be able to keep off their weight loss long term.
For weight loss after surgery, this is a study that was recently published comparing individuals who did not have surgery to those who had a sleeve gastrectomy in the green or a room-wide gastric bypass in the orange. And as you'll see for both a sleeve gastrectomy and a gastric bypass, weight loss is significant immediately after surgery and declines relatively quickly within 1 to 2 years of surgery. From there is some weight gain to be expected, which we will discuss up next. But we do see that the weight loss that is produced by the surgery, by both surgeries, is a durable weight loss and is significantly more than what we would expect from non-surgical interventions.
Like I had mentioned, weight regain is expected. It is not if someone regains weight, but when. What do you do? Significant weight regain of crossing over the 20% threshold of total body weight loss is seen in anywhere from 15 to 25% of all patients, but keeping in mind that this is also still more weight loss with the weight regain than we would have expected from other treatment options, namely diet, exercise, and behavioral therapy or anti-obesity medications. Now, with that weight regain does come the risk of developing those weight-related conditions again. We know that prevention is key. Physical activity is one of the best prevention measures, maintaining a high level of physical activity after surgery. Also, keeping track, weighing yourself regularly, keeping a food journal, keeping appointments and staying engaged in treatment, and also avoiding grazing. We will hear often from individuals that they are worried about stretching out their surgery. Case studies have shown that that is relatively rare. What is much more common and commonly seen with weight regain is grazing, where individuals are eating small amounts of food continuously throughout the day. We are an academic medical institution, so as a part of that, we do conduct research within our program. You may be approached at some point in time asking if you'd like to participate in research. Participation is completely voluntary, and it will not affect your care here whether or not you participate, but it is something that we ask that you consider if you are approached. To bring things full circle as to why come to Penn Medicine, we are a high-volume subspecialized center with experienced clinicians who specialize in treating high-risk cases. You get individualized attention coming through our process, and since we are an academic medical institution, you have access to the latest treatment options before they are typically widely available. If you decide that bariatric surgery is the right choice for you, the next step in this process would be to call your insurance company and confirm that you have bariatric surgery coverage under your plan. From there, you would call us to make an appointment at 215-615-7500. We are currently offering telemedicine appointments, and you would plan for that first telemedicine appointment to be up to 90 minutes, remembering that you are meeting with a nurse practitioner, a dietitian, and also your surgeon.
And with that, we have gone over the entire process and what you can expect if you decided to pursue bariatric surgery treatment here at Penn Medicine. Again, my name is Colleen Tewksbury. I thank you for your time. If you have any additional questions or if you'd like to schedule an appointment, please pick up the phone and give us a call at 215-615-7500. I hope to see you in the office soon. Take care.